Recording in. Good afternoon, everyone. My name is Dominic Akatiba. Thank you for joining us for our webinar today. Today, we're looking at hepatocellular carcinoma. And to do this, Dr. Emmanuel Atta will be leading us with this presentation with Dr. Atta, our head of Department of Internal Medicine, Upper West Regional Hospital, supervising him. Just some few points to note. If you try to unmute yourself, you'll be unable to. However, the chat box is available. Kindly put in your comments, questions whilst the presentation is ongoing. At the end of it, we'll open the floor so that you can electronically raise up your hand and then go ahead with contributions. So thank you so much for joining us for today. Kindly help me in welcoming Dr. Emmanuel. Dr. Atta, over to you. Thank you. Before you probably start, I'm sure Dr. Atta will say some preliminary comments and then you can take us through. Thanks.
Thank you very much, my very own boss, Dr. Akatiba, for the opportunity once again to educate the public on hepatocellular carcinoma. And one of the common causes or risk for hepatocellular carcinoma is chronic viral infections, hepatitis B and C, which we all know is predominant in our part of the world, which is the northern part, and even the entire country. And in a few studies that we've done so far, we've noticed that the liver-related problems actually contribute significantly to our mortalities here. So we want to use this opportunity to shed some light on hepatocellular carcinoma. So Dr. Atta would start with the presentation. Dr. Atta, over to you.
All right, thank you very much, boss. So I'm Dr. Emmanuel Atta, and I'll be presenting on hepatocellular carcinoma. Okay. Okay, so this is my outline for the presentation. I'll give a case presentation. I'll introduce the case, that is the literature. We look at epidemiology, risk factors, pathogenesis, some clinical features, how to make a diagnosis, look at the staging and prognostic scoring systems, look at the treatment modalities, and also how we can survey surveillance and prevention methods. So for the case presentation, as Dr. Atta just said, it's one of the common cases that we see in our setting. So I would like to present a case of Mr. P.S., 68-year-old male, who was referred from Lara Municipal Hospital on account of acute pancreatitis, chronic Hep C infection, and typhoid fever. So on presentation, his SpO2 was 98% on women, respiratory rate was 30 cycles per minute. His BP was 174, 106 milliliter mercury. Pulse was 115 beats per minute, and temperature was 37.3. RBS on presentation was 5 millimoles per liter. So he presented with abdominal pain of 3 days duration. He's known to have chronic Hep C infection and a known hypertensive about a year ago. He was in his usual state of health until 3 days prior to presentation. He began to experience severe generalized abdominal pain, which was worse in the epigastrum. It was gradual in onset. It was intermittent, had a aching and burning sensation, and usually worse after meals. It was initially relieved by over-the-counter analgesia associated with abdominal bloating after meals, but no vomiting. He said it was worse at night and it was graded 8 out of 10. So it was associated with headache, which was global. There was malaise, there was fever, there was nausea, early satiety, there was weight loss, there was anorexia, and there was some yellowing of the eyes, which the patients noticed about a year ago, which has gradually increased and worsened. He also complained of constipation. He also complained of a feeling of abdominal mass, which has progressively increased in size about a year ago, which was in the epigastrum, was not painful, but now very painful on presentation. He had completed 3 months of sofosbuvir daclitaspvir, which is one of the medications used in hepatitis C in August 2024, and then sorted to herbal medications. He's a farmer who drinks alcohol, but said he stopped about 2 months prior to presentation, and he does not smoke. So on examination, an elderly male looking chronically ill was in obvious pain, but not in respiratory distress. There was pallor. It was ecteric 3+. It was acyanotic. It was afebrile. He was moderately dehydrated with a delayed skin tegel and sunken eyes. Also, there was mild bilateral patent edema. No lymph nodes were palpated. On examination of the abdomen, it was distended. There was generalized tenderness, which was marked in the epigastrum, right hypochondriac, and umbilical regions. The liver was about 7 cm below the costal margin. There was an epigastric mass, which was firm with soft induration, smooth surface, non-mobile. It was quite tender. The spleen and the two kidneys were not palpable. Bowel cells were present and normal. Other systems were unremarkable for these patients. So an initial diagnosis of a suspected HCC, secondary to chronic Hep C infection and obstructive jaundice, secondary to query CA of pancreas, was made. So for investigations done, his full blood count showed leukocytosis with differential neutrophilia, moderate anemia of 10, and normal platelet levels. His liver function test showed elevated AST of 62.2 and an elevated ALT of 65.3. His GGT was also elevated. For his cholestatic fashion, total bilirubin was 264 and direct bilirubin was 165. Also noted was hypoalbuminemia. Renal function test depicted a normal urea and creatinine, but had hyponatremia of 129, mild hypokalemia. We also did a viral screen which showed Hep C positive, but both HIV-1 and B surface antigens were negative. Clotting profile showed an increase in INR, which was 1.41, upper limit of 1.3, and alpha fetoprotein down was 950 with an upper limit of 400. He did an abdominal scan also, which revealed an enlarged liver measuring about 17.4 cm with a diffuse heterogeneous echo pattern, multiple hypoechoic nodules noted within the parenchyma, and the largest measuring about 3.8 by 3.6. Also noted were mildly dilated intrahepatic ducts with minimal ascites. In the abdominal cavity to specifically the right iliac fossa, there were enlarged heterogeneous echo pattern and some indentation of its median lobe of the urinary bladder base. So an impression from the scan suggested HCC, that is hepatocellular carcinoma with minimal ascites and abdominal lymphoma. Now, patient was now transferred to the ward and the final diagnosis was made. One was HCC with BCLC stage D. BCLC is the Barcelona Clinic liver cancer stage, and we'll delve more into it. Secondary to chronic Hep C infection / chronic alcohol use, complicated by moderate hyponatremia of 129, mild hypokalemia, and also a spontaneous bacterial peritonitis. And second diagnosis was that he was a known hypertensive. So his BPs were noticed to be high on the ward and was passing hard stools. Stool frequency was about once a day. Well, the plan was that patient was to be counseled on the diagnosis and the need for palliative care, which was done. He was seen and counseled by the clinical psychologist and addiction specialist who actually spoke to the daughter to be present in all counseling sessions, and he was explained he was counseled more on his diagnosis and told what palliative care was. He was then discharged on tab amlodipine 10, indapamide, tab slow sodium, tab metro, syrup lactulose, 15 ml BD. He had completed 5 days of IV cefotaxime on account of the spontaneous bacterial peritonitis and was later switched to tab cefizine 200 mg BD for 7 days. He was also put on tab spironolactone 100 OD, furosemide, tab bisoprolol, tab thiamine, tab cocodamol, 1 tab TDS. Now, for these patients, a week after discharge, patients realized that there was some abdominal pain with increasing abdominal distension. He was also noticed to be passing multiple episodes of bloody loose stools and was rushed to a nearby hospital. Patient was realized to have ceased spontaneous breathing a day after presentation at the hospital and was then declared clinically dead exactly 10 days after discharge. Now, we are coming to the literature. It's very important for the case presentation because if you really get what happened in the case presentation, the literature will be very simple and we can merge things or put them in juxtapose. So for the literature, HCC, and I can be using HCC because we all now know that is hepatocellular carcinoma. It's one of the most common primary liver malignancies. It typically occurs in patients who already have an underlying history of chronic liver disease or cirrhosis. It develops from malignant transformation of hepatocytes. Now, even as we said that it occurs in patients who have an underlying history of cirrhosis, it can also occur in patients, that is about 25 of patients who have no history of cirrhosis or even risk factors for it. The dismal 5-year survival rate of approximately 22% underscores the aggressive biological behavior and poor prognosis that characterize liver cancer among GI malignancies. Now, what this statement means is that if you take 100 people diagnosed with liver cancer, only about 22 are still alive after 5 years. Now, this is measured relative to the general population of the same age. And it accounts for deaths specifically caused by the cancer and not from any. It resists chemotherapy and it can spread within the liver as satellite nodules. And even in 70% of cases after surgery, HCC can reoccur. Poor prognosis means that there's short survival rates and there's a highly likelihood of recurrence, as I just said. Now, in Ghana, it was noted in 2020 that liver cancer is the second most common cancer in both males and females. Worldwide, it represents the sixth most common cancer and the third leading cause of cancer-related mortality. About 900,000 new cases were reported in 2020. Dominance of viral hepatitis B and C in this parts of the world, as compared to the USA and Europe, which have low risk. Now, it is important to state that there is rising incidence in Western countries, especially in the United States, due to metabolic dysfunction-associated liver disease and also metabolic dysfunction associated steatotic hepatitis. This is because of the increasing risk factors such as obesity, type 2 diabetes, hypertension, and dyslipidemia, which is currently one of the high risk factors for HCC in the Western world. It has a male to female ratio of 3:1, and which we commonly see here in the northern region, especially Upper West, where most of our cases that we have are males, including the case that I presented. Now, when we look at the risk factors, for frequency, we can see that hepatitis B is one of the highest occurring risk factor for HCC, taking about 50 to 55%. Hepatitis C, about 25 to 30%. Alcohol-associated liver disease, about 15%. And as I mentioned earlier, metabolic dysfunction-associated steatotic liver disease, which was previously known as non-alcoholic fatty liver disease, and metabolic dysfunction-associated steatohepatitis, which was previously known as a non-alcoholic steatohepatitis, taking about 13%. But as I said earlier, it is on the rise. So we all have to look out for it, even in this part of the world. Also, there is aflatoxins B1 exposure, usually from also occurring usually in the sub-Saharan Africa because of the staple foods like maize and granules. Also, male sex and older age. And for age, it's occurring in patients who are about 50 to 70 years, but it has an earlier onset, about 25 to 40 years, especially in hepatitis B endemic areas. And what this means is that someone can be 40, but would have hepatitis B. He will not have hepatitis C till a later stage because hepatocellular carcinoma itself occurs in an advanced stage, or let me say symptoms usually occur in an advanced stage, as we are now coming to look at that shortly. Also, some additional risk factors include cirrhosis itself of any cause, occurring in about 80% of HCC cases, type 2 diabetes mellitus, hereditary hemochromatosis, alpha-1 antitrypsin deficiency, Wilson's disease, PBC, that is primary biliary cirrhosis, use of anabolic steroids, and also patients who have HIV plus a B virus co-infection are also on the risk of developing HCC. Now, when we look at the pathogenesis of HCC, it can be divided into two broad mechanisms. And I must state that it's also a multifactorial event. So for the two mechanisms, we have the direct and the indirect. So the direct means is that it's directly oncogenic. That is the word we like to use, that directly oncogenic. And it's usually with hepatitis B virus, which usually integrates directly into the host genome, disrupting tumor suppressor genes and activating oncogenes. Yes, so that's with the directly oncogenic. That's with the hepatitis B. Now, for the indirect, usually occurs through cirrhosis. And for us to understand how it occurs, I would like us to go through how cirrhosis itself occurs. Then we now see how cirrhosis will now develop to carcinoma. Now, when there is a persistent trigger, as stated, the Hep B, Hep Cs, the alcohol, the aflatoxins, occurring persistently damaging the liver cells repeatedly over time, there is release of inflammatory cytokines like interleukin-6 and the liver macrophages, which will create a chronic inflammatory environment. Now, this will lead to activation of hepatic stellate cells. Now, if you look at my cursor, I hope you can see my cursor. So when the damage occurs, necrosis is occurring, the liver is regenerating, but because of the persistent injury, we are getting good. Please, I hope everybody can see my cursor. Good. So because of the persistent injury, necrosis is occurring, there's regeneration also. Now, the important step here is the hepatic stellate cell activation. This is because in itself, these hepatic stellate cells are normal and they store vitamin A quietly. But when there is injury to the liver for a very long time, sometimes about 10 years to 15 years, these stellate cells now tend to transform into myofibroblasts. And now these activated stellate cells will now be producing excessive collagen and will be replacing the damaged hepatocytes with scar tissue. And this is what we call fibrosis. With continued injury, the fibrosis will now distort the normal liver architecture. Because if you remember from anatomy, there are some portal tracts, which usually connects to portal tracts this usually connects to central veins and all that. But this architecture, this nice normal liver architecture will be distorted. And surviving hepatocytes will now regenerate, as I said earlier, and will be constrained by the surrounding scar tissue, forming regenerative nodules. Now, when there is a combination of widespread fibrosis plus these regenerative nodules that have been formed, we say we have what we call cirrhosis. And at this point, the normal liver architecture is completely replaced, impairing blood flow, liver function, and creating portal hypertension. Now, from cirrhosis to cancer, usually the liver is scarred and crowded, as we have said. Now, the remaining liver cells are squeezed and they are usually under constant stress over here. And now, because the liver is constantly damaged, cells keep dying, and the liver keeps trying to replace them by making new cells over and over again. Now, every time a cell divides to make a new one, it recopies its DNA, and the more it copies, the more mistake it makes on its own. Now, some errors initially are harmless, but eventually we realize that these errors hit genes that control how cells grow and divide, and that would now lead to the cell itself to stop dividing or to die, what we call apoptosis. Now, when these genes are damaged, the cell will now ignore the stop signal as said, and it will start growing rapidly and not stopping. Now, this tumor or this cell that keeps multiplying will now form a mass, and that is what we call hepatocellular carcinoma. I hope I'm clear with my explanation. So we can see a noodle here now. Several noodles or regenerative noodles are formed. It's already a cirrhotic liver, and there are some factors over here that we'll talk about later. Also, when I talk about the multifactorial picture, we can see it here, and also we can also see that cirrhosis is giving us HCC, and we have the non-cirrhotic part also leading to HCC. So we have factors from the environment or co-carcinogens, usually chemicals like even tobacco smoking and use of pesticides can all lead to the non-cirrhotic pathway as well as the cirrhotic pathway and could lead to HCC. Not forgetting, there's also a positive, when there's a positive family history of hepatitis B or C, or even a more positive history of HCC, you are also likely to get hepatocellular carcinoma as well. Now, regardless of the trigger, these are the common pathways, the final common pathways that are involved. There's loss of cell cycle control, which is by the TP53 and RB mutations. There's replicative immortality. That is, the cell is always, the cell which is dead and on its own, it's creating a chronic environment to replicate more. And also there's uncontrolled proliferation from these pathways. Now, these are some of the subtypes of hepatocellular carcinoma. I'll take some few ones and go through them. So when we look at the steatohepatic type, which is associated with non-alcoholic fatty liver disease, or as I previously said, this is the old name. So metabolic dysfunction associated liver disease. This one has a more better prognosis as compared to other subtypes. We also have the clear cell, which mimics renal cell carcinoma. Now, the very one that is also better is the fibrolamellar type. In this case, you usually occurs in the young, and there is no history of cirrhosis. And when you check their alpha fetoproteins, it's usually normal. So we say that it is better if you resect. That is more curative as compared to non-curative. We also have the worst one being the neutrophil-rich type subtype, which is associated with the paraneoplastic syndromes, which we'll look at shortly. Okay. So for the clinical features of HCC, usually patients present at the advanced stage. They usually present at the advanced stage, but it can also be found on imaging. And when surveillance is done, there is elevated AFP. We are all trying to think of HCC. So usually they come with no symptoms, as they are asymptomatic. Now, in the advanced stage, there is usually a persistent right upper quadrant pain or a feeling of a mass. There's unexplained weight loss and anorexia. There's fatigue and weakness, early satiety, pruritus, spontaneous hemoperitoneum from a rupture of a hepatic nodule. Patients are usually cachectic. There is jaundice, which is usually obstructive, and there's a tender hepatomegaly. Also, we can find variceal bleeds from portal hypertension. There's increasing abdominal gait, that's ascites develops. It can be massive or moderate. Also, some patients come in with hepatic encephalopathy. Now, it's important to state that 70% of HCC cases are diagnosed at an advanced stage, as I said, but it's very important. 70%, that is very appreciable. And these patients are asymptomatic until the tumor reaches a large size or involves critical structures. Now, when we say paraneoplastic syndromes, what this basically means are that these are symptoms and biochemical disturbances. This is usually not caused not by the tumor physically, but it is invading or compressing the tissue and by substances that the tumor itself secretes, like hormones, antibodies, or cytokines. So I want us to think of it like this. You're in a two-bedroom and you have a neighbor next to your room, a tenant or someone next to your room. Now, this person is always playing loud music, very loud music that at night you cannot sleep. And not only at night, during the daytime, this music is not allowing you to study, it's not allowing you to go to allow you to do anything that you want to do in your room. And that is the nature of HCC. In itself, it is not there, but it is causing symptoms elsewhere. Now, it is important because these are some of the clinic features we have to be looking at when we have a patient admitted on the ward. Okay, especially hypoglycemia. This is because of the insulin-like growth factor 2, which binds insulin receptors and drives glucose uptake. It is also important to state that the tumor itself consumes large quantities of glucose directly. So any patient we have of HCC on the ward, we're always trying to do our RBS monitoring at least 4 hourly. There's also erythrocytosis with the production of ectopic erythropoietin production by the liver. There's also watery diarrhea. There's also hypercholesterolemia, which, as I said, the HCC cells will now be expressing themselves. That is, they lose the normal feedback inhibition of cholesterol synthesis. So it's always important to look out for these features and even do some clinical laboratory assessments for them as well. Now, for the diagnosis of HCC, we would like to do our full blood counts, which usually show a low HB, which is usually related to bleeding from viruses or other sources. We'll do our liver function test, looking at our transaminases. If I talk about transaminases, I'm talking about AST and ALT, which are usually elevated due to viral infection, even current alcohol use or other causes. Also, for the LFT, if you are looking at our cholestatic function, that's the bilirubin levels, they are usually elevated. And this is usually picked up at the advanced stage of the disease. Also, we can do a BUE and creatinine, which will show some increased creatinine level reflecting an intrinsic renal disease or what we call hepatorenal syndrome. And also, hyponatremia can also be found in patients with cirrhosis and ascites, and in itself can also be a marker of advanced liver disease. A clotting profile is very essential in the diagnosis of HCC, and we will see that in the Child-Tekotte-Pugh score when we are making our staging system for it. So a prolonged PT time or INR will reflect a significant impairment of hepatic function. And when that is there, we wouldn't think of curative methods like resection or transplant. Now, we have the alpha fetoprotein levels, which is usually more than 400 nanogram per milliliter, is diagnostic. However, it is important to state that alpha fetoprotein levels less than 400 does not exclude HCC, because sometimes you can have alpha fetoprotein about 200, but when you do your ultrasound and your CT scan, you can have some changes in the liver which are indicative of HCC. But for the purposes of literature, we say that alpha fetoprotein more than 400 is diagnostic. Also, we have the protein-induced by vitamin K absence or the antagonist 2 test, which is a blood test used to measure the levels of protein produced in the liver when there is absence of sufficient vitamin K. It's also one of the markers used. We'll look at that one too. And then the AFP-L3 fraction, which has a higher specificity. Now, for the purposes of diagnosis too, you have to do your hepatitis B surface antigen, you have to do your hep C core antibodies, you have to do your when there is increased iron saturation leading to an underlying hemochromatosis, one of the risk factors. Also, alpha-1 antitrypsin deficiency will show low levels of alpha-1 antitrypsin. And we have some markers that, when positive or negative, would include or exclude hepatocellular carcinoma. And one of the important ways of making your diagnosis with many carcinomas is liver biopsy. However, because of the risk of bleeding and tumor seeding, we try to avoid as much as possible to do our alpha fetoprotein, our ultrasound, our CT scan before, when we cannot really see nothing going on, but still there's a high suspicion of HCC, then we go ahead and do the liver biopsy. Now, for the diagnostic imaging, we have ultrasound, CT scan, and MRI, with CT scan being the most specific for HCC, the triple phase CT scan. We'll come to that. However, when we are on the ward, we like to do our ultrasound, which usually show a round or oval mass with sharp, smooth boundaries. The lesions may range from hypoechoic to hyperechoic, depending on the surrounding parenchyma and the degree of fatty infiltration. Also, the use of Doppler analysis to characterize the lesion can also be helpful, in that HCC is more likely to have a significant arterial blood supply and neovascularization as compared to regenerative nodules. Now, for a triple phase CT scan, we are doing a non-contrast CT scan, an arterial phase CT scan, and also a venous phase, or what they call the delayed washout phase. Now, for you to diagnose HCC, you must have a highly vascular pattern on imaging when you are doing your arterial phase, also known as the arterial phase hyperenhancement, where if you look at this place, so when you are doing the CT, you do your non-contrast, and now when you apply the contrast now, if you look at this liver here, you can see that it looks brighter or it's highly vascularized, because usually it's the arteries that are usually involved. So it looks very highly vascular. That is, it has a bright pattern. Now, when you take it out from the arterial phase and you come to the venous phase, there's what we call washout. Everything that you saw in the arterial phase now vanishes. And when you see this kind of pattern, we are trying to say that it is more of hepatocellular carcinoma than any other thing. MRI would also show non-REM arterial phase hyperenhancement relative to the liver and parenchyma. Sometimes too, you can have REM enhancements in MRIs. Also, a non-peripheral washout appearance may be seen, where you would see hypo enhancements when compared to the liver in portal venous or delayed phases of contrast administration. Also important is the enhancing capsule appearance. You will see a smooth border around most or all of the lesion that enhances visibility in the portal venous or delayed phase of contrast administration. Important in MRI is also a more than 50% growth increase in size in less than 6 months of a nodule or the mass. All right. So for the diagnostic scoring system used in HCC, we have the LIRAD scoring system, the Barcelona Clinic Liver Cancer, which is more of a staging and prognostic scoring system, and is used in treatment evaluation as well. We also have the GALAT score, which we'll look at it briefly, and also the European Association for the Study of the Liver criteria, which usually plus the arterial phase hyperenhancement plus one washout on one imaging modality for lesions more than 1 cm in cirrhotic liver. Now, for the staging and prognostic in HCC, we are looking at 4 features that will allow you to determine the overall survival of the patient. Okay, so now we are looking at the severity of the underlying liver disease. We are looking at the tumor size. We are looking at the extension of the tumor into adjacent structures and the presence or absence of metastasis. Now, the 4 most commonly used staging and prognostic scoring system is the TNM system of the Combined American Joint Committee on Cancer, the Okuda system, which is more of a Japanese staging system, the Barcelona Clinic Liver Cancer system, which we usually use here, and the CLIP score, which is the Cancer of the Liver Italian Program score. Now, for staging and prognostics, we are using the BCLC, that's the Barcelona Clinic Liver Cancer staging. Now, if you look at it here, I'll go back to the previous slide. We are looking at the performance status of the patient. We are looking at the tumor size slash if there is any portal invasion or not. We're also looking at the liver function. We use the Child-Pugh score and also giving you treatment modalities, as I said. So now, for your performance status, 0 is telling you that the patient is fully active, no performance restrictions. 1 is telling you that there's strenuous physical activity, which is restricted, but there's full ambulation and patient is able to carry out light work. Also, 2 is telling you that the patient is capable of self-care, but unable to carry out any work activities. 3 is telling you that is capable, but with limited self-care, usually confined to bed or chair with more than 50% of waking hours. And 4 is making you know that the patient is completely disabled, cannot carry out any self-care, and is totally confined to bed. Now, the Child-Pugh classification, I like to use the acronym ABCDE. So A is looking at the albumin level. We use the grams per liter here. So a score of 1 is 35 grams per liter. Score of 2 is 28 to 35 grams per liter. Score of 3 is less than 28 grams per liter. Now, to make this more practical for us, I would like us to use the case that I presented to get a ECOG performance status for the patient, as well as look at our scoring for the Child-Pugh classification. Now, I said Child-Pugh, we have the albumin, that is A. B is for bilirubin. C is for clotting time, that is the prothrombin time, or INR, or coagulation studies. D is when there is distension, that is looking at ascites, whether it is absent, slight, or moderate. And also E is encephalopathy. Now, a total Child-Pugh score of 5 to 6 is considered as class A, that is the patient is well compensated for. 7 to 9 is class B, that is a significant functional compromise. And 10 to 15 is class C, which is more of a decompensated disease. Now, for our patient that we had on the ward, he was capable of only limited self-care. He was usually confined to bed, and so we'll give him a score of 3 for the performance state. Now, this patient had slight ascites, if you remember from ultrasound findings, and even on examination, there was slight ascites. His bilirubin level was more than 51.3, so we have 2 already for ascites. More than 51, that would be 3, that making it 5. His albumin level was 34 grams per liter, so he has another 2, making it 7. His prothrombin time, so we did an INR for this patient, so we are using the INR over here, which was less than 1.7, making it 8. And encephalopathy, patient came in confused at the time of presentation, so we give him a grade 1, which is also a score of 2. So combining this, we have a score of 10 for this patient, which is a class C, and an ECOG performance status of 3. So putting this into perspective, or delving in, if some of us would remember, we made so let's stage it together. So the performance status was 3:4, so it's 3. So this is it here. Were there multiple nodules? So for the tumor size less than 2 centimeters is stage 0. Single or 3 nodules, but less than 3 centimeters is stage A, BCLC. When there is no vascular invasion, but there are multinodular, which our patients had, is stage B. So for the tumor size, any accounts for this patient. Now, for the Child-Pugh score, we realized that the patient was class C. So that is also here. And the best treatment for this patient was palliative. And as we can all see here, what they have here is the best supportive care. And the survival rate is also less than 3 months. And for our patients, it was actually less than a month for this patient after discharge. That doesn't mean that after he was discharged, as I said, this is an advanced stage. HCC occurs in the advanced stage, or his patient presents in the advanced stage. So it could be happening for a very long time. I don't actually think the Hep C was diagnosed just about a year ago. This patient has been with it for a very long time, because seeing the patient even his jaundice was very high. If you look at his the bilirubin was also very, very high for this patient. And that's what even led to the suspicion of CA head of pancreas. But everything with the ultrasound, with our AFP, we're able to make a full diagnosis of hepatocellular carcinoma stage D for this patient. Now, for the treatment modalities of HCC, I must say that HCC is a multidisciplinary approach. You need your medical oncologist, you need a hepatobiliary surgeon, very important. Sometimes in the Western world, there's transplant hepatologists, there's interventional radiologists that we now have in Ghana, we now have radiation oncologists, even the dietitians are involved, and also the clinical psychologists, very important in the counseling of the patient and his or her relatives. Now, as said earlier, treatment selection is guided by the BCLC staging, the liver function and performance status, which are all embedded in the BCLC. So some curative methods is usually through surgical resection. I would have loved to go through the anatomy, but for the sake of time, we will just take it like this. So when there is Child-Pugh class A, and there's no portal hypertension, and there's adequate liver reserve, we try to go for more of the surgical resection, which is usually best for single tumors. Also is the liver transplantation, where the Milan criteria is used. So when there's a tumor size of less than 5 cm or less than 3 nodules and less than 3 centimeters, as we noted in stage B of the BCLC, we try as much as possible to do the liver transplant when there is donor organ availability, usually done in the Western world. There's also radiofrequency ablation where the tumor is less than 3 centimeters. So you want to use heat or chemicals to remove the functional or the carcinoma which is occurring. And there's also microwave ablation. These are all types of ablations that we can do to resect for smaller tumors. Now, there is also the transarterial radioembolization. So these are what we call the local regional therapies, transarterial radioembolization and the transarterial chemoembolization. So transarterial radioembolization is usually useful for portal vein invasion cases, and there's also evidence for downstaging to transplant. So you can start that before you transplant if you want to do that. If you want to transplant the liver. Now we have the transarterial chemoembolization, which is standard for BCLB intermediate stage. Okay. Now, most important is the systemic therapy. For the systemic therapy, we usually use sorafenib or lenvatinib. In our case here in the upper west, what we usually prescribe for patients is sorafenib. However, the preferred first line for HCC systemic therapy is to use atezolizumab and bevacizumab. These are the preferred first lines, and generally worldwide, that is the preferred first line for all. There's also second line like regorafenib, cabozantinib, and ramucirumab. We can also do some immunotherapy for the patients. Now, we'll now look at surveillance and prevention methods used in HCC. I must say that with the rest of the world and in our setting, that is in Sub-Saharan Africa, patients with HCC have the lowest survival rate. This is partly due to the late presentation of HCC with advanced symptomatic disease as a result of underdeveloped surveillance practices. Moreover, access to care and resource limitations further limit outcomes for the patients who receive a diagnosis in Sub-Saharan Africa. So for us here in Ghana, what we are now doing is that anybody who presents with hepatitis B or C and is having, some jaundice, is having this paraneoplastic syndromes, first thing we try to do is do an ultrasound for these patients and do our alpha fetoprotein, and that could lead us to make a diagnosis. Now, who can go under surveillance and how is this done? So it's very simple. Any patient who we diagnose of cirrhosis, for all clinicians, irrespective of the cause, you would have to do your surveillance for these patients. And also hepatitis B virus carriers, even without cirrhosis, it's better to pick it up early than to wait till the patient now becomes a chronic Hep B infection patient before you do your AFP or your abdominal ultrasound. Now, how is this done? Another simple way, you do your abdominal ultrasound plus or minus your AFPs, and this should be done every 6 months. Very important. Every 6 months, you're supposed to do at least an abdominal ultrasound or alpha fetoprotein for this patient. Now, what is a positive surveillance? In our setting, when we see a nodule less than 1 cm, we have to repeat the ultrasound in 3 to 4 months. We don't have to wait for the 6 months period. We repeat it in 3 to 4 months. When we see a nodule of 1 to 2 cm, we are looking at a contrast image. That's a CT scan. That is very, very important to also do that. And also when the nodule is more than 2 cm, straight away we are going to do our triple phase CT scan, or we use our MRI, which will help us in the LIRAD scoring, diagnostic scoring system that will enable us to treat the HCC as quickly as possible, or sorry, to diagnose the HCC as quickly as possible. Now we have the APRI score and the GALAT score. So these are also predictive of liver cirrhosis, or how, yes, predictive of liver cirrhosis, especially with the APRI score. We usually use it here for patients with hepatitis B, especially, and hepatitis C. If you have your amino, the AST, so what you usually do is that if you have maybe whatever your AST is, what you do is you look at it, you divide it by the upper limit of the normal range, which is usually 40 worldwide. You now multiply it by 100, and then you divide it by the platelet count. Now, for the APRI score, usually less than 0.5, we would say there's no liver cirrhosis, but 0.5 to 1.5. So these are the markers, 0.5 and 1.5. So less than 0.5, usually not usually predictive of liver cirrhosis. 0.15 to 1.5 is usually moderate. And when the patient has a APRI score of more than 1.5, you should go straight ahead to do your AFPs and your ultrasound, which I know that by now we would have already done it, and we move on. We also have the GALAT score, which is also a serum-based scoring model, which is also used in diagnosis, as I mentioned earlier. So we usually give a score of 0 if it's a female and score of 1 if it's male. We also look at the age, increasing age, look at the AFP L3 levels. We look at AFP, so the alpha fetoprotein, and we look at the PIVCA2 score. Now, for prevention of HCC, we can divide it into primary, secondary, and tertiary. So for primary prevention, we are looking at hepatitis B virus vaccination, which has been proven to be highly effective in all cases, or let me say in most cases, and has been adopted by the WHO universally. So even in the North here right now, it's been adopted. I think not only the North, I think in Ghana now, the hepatitis B vaccination has been adopted to be given to children immediately after birth. Also for hepatitis C, you want to look at harm reduction, blood safety methods. Also aflatoxins dietary reduction, that is the maize, the way we store our items, the way we are even producing them with the chemicals and all that. Though the aflatoxins are usually intrinsic in the foods, most of the foods that we have. Also, addiction specialist is very important for patients who have alcoholic issues. Now, for secondary prevention, we are looking at targeting, treating those who are already infected. We are looking at using tenofovir or entecavir for patients in a B. Usually, we use TDF or tenofovir alafenamide in treating patients with hepatitis B virus. And this reduces the HCC incidence by about 50 to 80%. In Hep C virus, you also want to use your direct antivirals. So there was one that I mentioned, sofosbuvir daclizazole, and there's also sofosbuvir ledipasvir, which are also very important because you want to look at the ones that are pangenotypic and the ones that are not in giving your patients. You also want to look at your statins. I said hypercholesterolemia occurs in patients with HCC, can either be from most likely from the paraneoplastic syndrome. Tertiary prevention, we look at the adjuvant antiviral therapy post-resection, also looking at sorafenib post transarterial chemoembolization. Now, atezolizumab and bevacizumab has been noted to be the current first-line standard for advanced HCC with overall improvement in survival rates. And as said, every 6 months, when you are doing your ultrasound and your AFP, you should always do that in high-risk patients, which is very critical for early detection. Now, these are some of the key takeaways that I would like all of us to focus on. So as said, HCC is the third most common cancer globally and predominantly arises in the setting of chronic liver disease and cirrhosis. leading risk factors being chronic Hep B and Hep C. But now in the Western countries, it is increasing rapidly because of the metabolic dysfunction-associated steatohepatitis and that of fatty liver disease, which is on the rise because of obesity, dyslipidemia, hypertension, and type 2 diabetes. Also, for the diagnosis purposes, we also want to always do your CT scan, that is the triple phase CT scan, or your MRI with the Lirac scoring system. Also, you want to do your AFP, alpha fetoproteins. And as I said, your biopsy is not always required because of the risk of bleeding and tumor seeding. And always, you want to do your BCL staging, which guides your treatment selection from curative resection or transplant to systemic therapies, as well as local-regional therapies. These are my references. Thank you very much.
Legendary. This has been excellent. Thank you so much for educating all of us this afternoon on hepatocellular carcinoma. I'm sure I have learned a lot. I'm sure lots of those who have joined us have learned and updated themselves. And like Dr. Atto mentioned, we hope that with the current prevalence of Hep B in our country, Hep C, viral hepatitis, and now it's virtually like a double whammy, right? With the MASH also coming up, we need to really, especially those of us who practice in northern part of Ghana, be on the lookout, treat the patients appropriately, primary prevention, get the vaccination done, midwives on the call. The schedule has changed. If you look at what we call the WAYUM books, the EPI, the vaccination is no more starting at 6 weeks. It's starting on the day of birth. So let's not wait till the people go home and acquire the infection, and by the time they are in, they're already hepatitis B infected and the vaccine doesn't work for them. So for whatever reason, I don't know why you flip to the child health records, the page that has the EPI, you realize that OPV is given, BCG is given, the place written hepatitis B is left blank. And it's just terrible, especially in our part of the country, the northern Ghana, where there's a lot of prevalence. Ghana is already prevalent for Hep B, but the prevalence is even more up north. Hepatitis C, I'm happy to announce as well that the Stop Hepatitis C program has taken delivery of the cure medicines, the pan-genotypic medicines, the directly acting antivirals. And these are given for free. So kindly contact your regional hospital people. So if you are in the Upper East, the regional hospital guys, Dr. Anafo and co have them. Then I'm aware of Sandema, Joshua. They also have, that's a center as well. Upper West will do as well. So there's no reason why you have hepatitis C now and you shouldn't be on the cure medicine. And head to toe has been the issue with money. Now, if it's being given for free, you got to go through the diagnostic workup and be put on the treatment. So thank you so much, Dr. Atta, for an excellent job done. It's a lot of volume to process. But the good thing is that this is being recorded and will be put up on our YouTube channel like we always do. So check in the chat box. I've put the link to the YouTube channel there. You can subscribe and then have all of those presentations as well. If you want to join us on social media to know about the topics we are presenting and the various donation programs we are doing, I've shared all of those links, whether you prefer a Facebook, a LinkedIn account, or even a WhatsApp channel. It's all been put in the chat box. So just look through and then you can have all of those details. So let me let Dr. Atto come in and then we can take the questions. So Dr. Atto, over to you.
Thank you very much, Dr. Akatiba. Anytime we discuss liver-related issues, I think we tend to have a lot of engagement and interest. So it's good. Like you said, currently Ghana is doing more than the 8% limit that the WHO has given for us to be endemic in terms of the seroprevalence rate for chronic hepatitis B. So we are definitely endemic, and most of our hepatocellular carcinomas are coming from chronic hepatitis B and C. And now we have a subset of patients coming with hepatocellular carcinoma from chronic alcohol abuse, and it's very sad. We are beginning to see a lot of it now also in our clinics and at the emergency. So those who also consume alcohol, you have to be careful. That's just on a lighter note. So I just want to reiterate a few things that has been said, and I think Dr. Arthur did a very good job, very excellently presented. So somebody wanted to know, so maybe I'll just start with there are novel biomarkers that are being used increasingly in the Western world. It hasn't really caught up with us yet, but Arthur, if you could send the slides to where you have the PIFCA2. So PIFCA2 is also one of the novel biomarkers that has a very high sensitivity for detecting early hepatocellular carcinoma. So it's not just the alpha fetoprotein that can be used. And now there are a lot of novel biomarkers that are coming up, and the PIFCA2 is one of those biomarkers. And once you have a patient whose alpha fetoprotein is more than 400, it is not exactly diagnostic, but it's suggestive, especially in the context of enlarged liver nodules, cause parenchyma echo pattern, and alpha fetoprotein of more than 400 is definitely suggestive. So that's something we need to take note. And the AFPL3 fraction, like you said, tends to have the highest specificity, which we don't usually do routinely. You made, I think, in the course of the presentation, Dr. Arthur made a comment about patients with the patients that are qualified for the local regional therapy if they have portal vein invasion. I just wanted to clarify. The portal vein invasion is usually for advanced. So once you have portal vein invasion, it means already you are systemic. So the treatment is systemic and is not local regional. So at that point, you don't want to do TACE or TARI. You are doing TACE or TARI when your portal flow or your blood supply is preserved and your nodules are well circumscribed, or you can be well characterized, so that when you directly inject the chemo into them, you can cut off the blood supply. So the tumors die from the cytotoxic effects of the chemo, and also from the ischemic embolization that ensues from cutting off the hepatic artery supply. So the rest of the liver can be supplied by the portal vein. So I just wanted to make that correction. Then also, yes, especially for patients, I just wanted to say for patients who have already developed cirrhosis from chronic hepatitis C, even when you cure the chronic hepatitis C, remember to still do the surveillance for them for hepatocellular carcinoma, because it doesn't absorb them. It doesn't stop or prevent development of hepatocellular carcinoma. What it rather does is to reduce the risk, but there's still that added risk. Once you develop cirrhosis from FC before you are cured, that cirrhosis, even though you've been cured from the chronic hepatitis C, that cirrhosis still remains a risk for hepatocellular carcinoma. So such patients need to be followed up with 6-monthly alpha fetoprotein and abdominal ultrasound scans, okay, to mount. So those people, you always have to do your surveillance for them. So, I mean, these are the few things I just wanted to add on to, but that was a very good presentation. And as always, we've learned a lot from the presentation. So maybe we'll take the questions, some of the questions that have been asked, as much as time may permit. Then, yeah. So thank you very much for tuning in and for listening. So, okay, so someone, someone shared a paper. Thank you for the paper. I think it's a very good paper. So this is an interesting paper, and also an eye opener for us, especially clinicians. And I think the paper is in the chat box, so we can look at it. So the challenge is because most of the patients come in very advanced, so BCLC stage C or D. Most of the time, when we tend to even see patients who come in early, it doesn't really click to us. So that's why Dr. Arthur mentioned that the care must be multidisciplinary. And here we've actually referred patients to the hepatobiliary surgeons where they've had their HCCs resected. And we've had very good results with it. And they came back to, thank us for referring them and all. So for us, what we try to do is anytime we see a patient, we try to stage. Once we try to stage and you're advanced, then we know that it's just palliative or systemic therapy. We put you on sorafenib. But once you fall anywhere between stage 0, stage A, stage B, we always refer them, because even for those with stage B, there's always a chance that they can still get transplant or resection if they qualify and they meet certain criteria, especially the Milan criteria. So we've referred a few and they've gone to Kolebu to have the resection and they've come back to thank us. So we shouldn't also automatically put every patient that we see, assume they are advanced and put them on sorafenib and discharge them to go home. Let's take our time to properly characterize them and find out which stage they are, because some of them actually qualify for resection or transplant, but we just end up putting them on sorafenib. They go, it progresses further, then now we can't do anything about it. So that's just what I want to say. Yes, Agomina, most of the patients present late, so they are not candidates for surgical intervention, and the cost of taste, study, and the skills to do it in Ghana is not readily available. That's very true. So it's also very expensive because you need to have an interventional radiologist who is very skilled at that, and it's very, very expensive. So you're right. And yes, the MEL score can also be used for selecting patients for transplant. So it's an important point. Except that the MEL score also has its limitations. You can still have a very high cancer risk despite having a low MEL score. So always use it as an adjunct with other things and not a standalone. So I think I've already answered Kwabine's question. Yeah, so it's not exactly true that it's the only one we use for diagnosis and monitoring, even though currently in Ghana now, yes, that's the only one we are using. But elsewhere, new biomarkers are out there and it's being used. And I think Dr. Katiba has already responded to the hepatitis B issue. Okay. How do you manage pregnant women with hepatitis B? Okay, so the presentation is on C, but so for pregnant women who have hepatitis B, if they were already on treatment before they got the hepatitis B, then you keep them on their treatment. Don't tamper with it. But if they were not already on treatment and they are diagnosed of hepatitis B, of course, once you establish chronicity, which is the first thing you do, you have to try and do a viral load and their e antigen status. If you look at the expanded eligibility criteria, WHO 2024, for pregnant women now, you only treat them if their viral load is more than 2,000 international units per mil, and you have to start the treatments from the second trimester. All right, so that's it for. If they cannot afford the viral load, then according to the WHO, you can use their e antigen status. If it's positive, you can go ahead and treat them from the second trimester. However, if you don't have access to any of those things, then it means you just have to wait till you get at least e antigen status or the viral load. You don't go and use APRI score or any of those things to make a determination to treat a pregnant woman, because normal pregnancy physiology will affect their liver function test. So that is not used. I hope that answers your question. Please, the bed dose of hepatitis B is not practiced as per the schedule. Okay, so Dr. Katiba has also responded to that already. Does it necessarily mean with liver enzymes? The liver enzymes must be about 1,000. I have worked with some bosses who say that is it always the case? I'm not sure I understand your question. Are you talking about liver enzyme in relation to hepatocellular carcinoma? If that's what you are talking about, then not necessarily. In making a determination to treat patients with hepatocellular carcinoma, you are not only going to take a decision, or it doesn't necessarily mean your enzymes must be more than 1,000, please. You have to use the Child-Pugh score, then you have to use the size of the nodules that they have, the ECOG performance status as well, to do the staging, and based on the staging, you'd know what sort of treatment to give. All right. The majority of HCC in our population is caused by HBV. Up to 61% may be eligible for curative treatment. trans-arterial sorafenib, this percentage may be increased with a robust surveillance for patients at increased risk for ACC. Hep B muscle, yes, you are right. So that's like we said, most of them may qualify, but I think that there's a lot of inertia also on our part, and most of the time we just put them on sorafenib and send them away. But we must necessarily do the staging for them, find out what stage they are, and refer them appropriately. If they come in very early, you pick up just one nodule. Don't waste time. Just refer them to the hepatobiliary surgeon because they may qualify for a resection or a transplant. If they can afford it, just send them away. Even if they cannot afford, tell them that there is something that can be done to them. Some of them will definitely get the money and go and get the resection or the transplant done. And we've done a lot here. We've sent them away. They've gone for the resection and transplant. They've come back to thank us. So let's not, by default, put all of them on sorafenib. How do you diagnose the HCC subtype with normal AFP, especially when the transaminases are not very suggestive? Well, that's a very good question, Jonathan. So, just like Dr. Arthur mentioned, you have to look at everything in totality. So, if your AFP is not suggestive, and we had a few patients where the AFPs were not suggestive, there is a specific way that the ACC behave when you do your triple phase or your triphasic CT scan. So if you have a patient that is coming in with maybe ascites, hepatomegaly, jaundice, a patient has a history of chronic hepatitis B or hepatitis C, and you suspect ACC, but your AFP is normal, and you do your scan, and your scan is still not suggestive, just do your triple phase CT scan. Once you are able to demonstrate arterial hyperenhancement and early washout in your delayed portal or venous phase, that is it. That is it. So you don't really need to do anything again, unless you do your triple phase CT scan and that is still not suggestive. And those are the people that eventually you may want to refer for a biopsy. I hope that answers the question. All right. So MRI with gadolinium contrast is far superior than Primavest. 60% of gadolinium is excreted by the liver. Okay, thank you very much, Agominab. Agominab, I would like to know, are you a physician with interest in hepatocellular carcinoma and chronic B? I like your contributions. Maybe if you are, you can let us know. Thank you. Okay, so over to you, Dr. Katiba.
Fantastic. Agobnab is a legend. I think he's a hepatobiliary guy or wanting to cure all of our people with liver issues by ensuring that his surgical skills are put in earlier. He's a legend. Thank you, Romanus, for all the comments that you have brought up, and to all those who have put comments in as well in the chat box. We are grateful. I think we've gone past the hour. I just wanted to chip in that the triple phase CT scan is not the same as contrast CT scan. So one of the things that unfortunately, I don't know for whatever reason, people just request for a CT scan or contrast CT scan, and this doesn't allow the radiologist really to, except maybe somebody who goes to really read what the indication is for the CT scan. Otherwise, sometimes, especially like prior to we having a resident radiologist, typically is usually the radiographers or the sonographers who are in charge of our radiology units most of the times at in northern Ghana. And so when you request a search, a couple of times they just hit in the contrast and then they're taking the images. It may not characterize what we are really looking for. So if you are making the request, please make it appropriately. I've seen Agomna putting in that he's a general surgeon trained in South Africa. I know, I'm just adding that you have a special interest in the liver, right? Thank you for all of what you do. So in the absence of any other comments, we want to say a big thank you to Dr. Atta and Dr. Atto for an excellent job done today, bringing us all up to speed with hepatocellular carcinoma. I think the key word out there is that we should look out. Surveillance is key. Let's not just remain in the status quo and sort of keep to sorafenibing everyone who has hepatocellular carcinoma. There's a good prognosis when they appear early. prevention is even better than cure. And so, like we keep highlighting, please, 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 let's save our infants, let's save our newborns as much as possible. We should always wait for the white man to have to donate vaccines through Gavi. We can all put in the advocacy so that that birth dose, which has not been donated or given by the Global Alliance for Vaccinations and Immunization, Gavi, but has been put on our EPI, because the thing is not given for free by the white man. We always leave it. We leave it out, and we don't get the people to receive the birth dose of the vaccine. It is no crime for a newborn to be born in Ghana. That because by virtue of the fact that you are born in Ghana, you contract hepatitis B because one, either your mother or your household may have, or your health service providers do not do the right thing by giving you the hepatitis B vaccine. So let's help. Let's help to reduce the incidence and reduce the prevalence of Hep B, Hep C, and the related etiologies. The worst part of it is that up north as well, the incidence of alcohol intake and alcoholic liver disease is also high. Lots of people just drink, they drink off their heads. So, really, like Dr. Ato mentioned, we need to be careful. Let's continue to advocate, let's continue to highlight this in our public health education. And I'm sure we'll be able to, just like Thailand did, bring our country out of the endemicity for hepatitis B, and by so doing, be able to reduce the hepatocellular carcinoma rate. Thank you so much, and God bless all of us. Till we come your way next week with another presentation, wish you all the best. Have a blessed Easter. Bye-bye.